On to item number 10, which is a presentation from the board will be receiving a presentation from the Department of Health and Human Services on their programming and services. And I believe we'll be hearing from Director Mann. Welcome.
Welcome. Yeah, welcome. Well, thank you. Welcome to my world. Carolyn Mann, Health and Human Services, and go ahead.
And Anna Scott, Health and Human Services.
And we're going to do a little song and dance.
Oh, good.
If you don't mind. Thank you, Darcy. So, we wanted to provide you today with a broad stroke overview of Health and Human Services, recognizing that the scope of what Health and Human Services does is pretty broad. And we're hopeful that some of the more detailed kind of stuff that's more division-based we can do in future workshops. But I want to start with our mission, which is strengthening resilience and well-being in our community. And we've worked under a similar type mission for as long as I can remember. However, when I became the director in 2017, our team came together and each program and division developed their own individual mission statement that guided the programming and services that they provide. We then pulled all those together and pulled out the common themes and common words, and this really resonated with our team. So this is a team-driven mission, and our team from top to bottom, not that there's a bottom, but top across, strive to make this a reality in our community. Go ahead. So we're a team led by senior leadership, which includes our deputy directors over our 4 major divisions, which is aging and social services, behavioral health, fiscal oversight, and special operations, and public health and prevention. Our assistant director, our senior PICA manager, which is program integrity and quality assurance, and then my assistant, who provides secretarial administrative support to Anna and myself, and is the go-to person for our senior leadership team. This team leads, we have an authorized staff in Health and Human Services of 155 people. 4 of those positions are COVID specific. So they are slated to sunset in the next year or so. 4. So, and as with, many of our programs and positions and other places in the county, we do experience vacancies periodically, and we're going to be talking a little bit about that as one of our challenges, because I think right now we're staffed at about 120 people, and are recruiting for those other positions.
I don't know that I've heard Pika yet. Like Pikachu?
It is. Well, yes, we took a position we had previously, the management analyst, and because of the broad scope of what it did, which is really around our internal civil rights compliance, the HIPAA compliance officer role, a number of roles that person has, in addition to leading a team of analysts that work with programs to ensure compliance and quality improvement, and those types of initiatives that are internal. We've renamed it the PICA manager. I have no idea why. I can't remember. Do you remember?
It's Phil.
It is Phil. Stephanie Tanksley is our senior PICA manager, and she's right now filling that role, and she's acting as our interim public health deputy director also.
Okay. And these with the way the lines go, these deputy directors, do they report to Anna?
Yes,
Okay, Anna reports to you.
that's correct. And then the PICA manager reports to me also in order to allow for differentiation between program and service delivery and the person who's doing quality assurance and quality integrity assessments.
Cool.
Okay, go ahead. So our role in administration is really to provide that leadership and direction and program coordination across all divisions. We are also the people who lead department-wide initiatives. We have deputy directors who lead more program-specific initiatives, but we have some broader department initiatives that we'll be going over shortly, and it's our role to lead those. We also do personnel management and compliance with county policies and internal and state requirements. And then our program integrity and quality assurance, which we spoke about it a little bit, but it's that internal program monitoring across divisions, quality assurance on our child welfare and home supportive services cases, HIPAA compliance, compliance with civil rights, equity and diversity, and program evaluation and outcome development. And then finally, our other role is that public relations role with our internal and external partners and making sure that we are, working together in partnership within our county departments and community, and helping foster good relations that make for more productive working outcomes. Okay.
All right, we're going to switch off a little bit so we don't lose our voices. So I'll talk to you a little bit about in a little more depth about the divisions and the programs that we run in Health and Human Services. But as Marilyn said, we'll be bringing back more in-depth workshops to really dig in, because each of these divisions has a wide range of programming that they're administering. So briefly, we'll go through the main functions of each division. In behavioral health, we're responsible for providing the mental health services to those who have a serious mental illness, and particularly focused on our Medi-Cal populations, as opposed to some of the more mild to moderate and more manageable mental health issues. So our focus really is to treat those who have mental or behavioral health disorders that really result in very serious functional impairment. So that's the primary focus in our mental health program, and we are the managed care plan for the mental health Medi-Cal carve-out. We also provide substance use disorder treatments, assessments, and prevention. We have a charge to administer the Mental Health Services Act, which is funding that has come down as part of a assessment on those who make a very high amount of money in California. And it's intended to really improve the system of care for mental health across the board, and not necessarily focused on those with a severe mental illness, but really focusing on prevention, early intervention, and then also supportive services for those who are currently experiencing a mental illness. Under the MHSA, we operate 2 wellness centers, one in Bishop and one in Lone Pine. And the focus of these centers is to help support those who are living with a mental illness by providing peer support and other supportive services to allow people to live independently whenever possible. We also have a residential facility, Progress House, in Bishop that has 12 beds. So that is not a locked facility, but it is a licensed facility where we provide safe residence for individuals who have a severe mental illness. Yes.
And you don't have to answer this now if you don't know it, but do we spend all of our MHSA allocation?
Not on a yearly basis. The allocations come in, and we have a plan in place that runs over a 3-year period. I believe, don't correct me if I'm wrong. Those do continue to roll forward. So we plan to spend them, but if we have staffing vacancies or some other reason that the funding has not been spent, it'll continue to be available in trust for a period of time. At some point, some of it unspent money over a period of time may revert. But
Okay, apparently statewide it's an issue, and as everyone points their fingers is why homelessness hasn't been solved. The governor's like, well, counties aren't spending their NHSA.
yeah, and one aspect of that is to support people in finding housing and supporting their housing. Did you want to add something?
No, I think, and you're right, this is a statewide issue. It is, in some ways, it has allowed for more flexibility on how we meet the needs of our population of persons who might be struggling or in early stages of a mental health illness. But some of the restrictions on, for example, there's innovations funding is part of the MHSA funding stream. And you have to have your innovations plan approved, and your innovations, it has to be something, truly innovative and something that might be innovative in another county that you want to implement and try out in a rural county may or may not be approved by the state. We've had a real struggle with that area at times. But I think one of our biggest challenges is oftentimes that staffing turnover and staffing holes that then, we budget to use the money and then end up not being able to use it. But I do think that as it relates to addressing the issue of homelessness, our wellness centers routinely are, available as a resource to help coordinate, case manage, provide supportive services, even if it's a shower and a place to get your laundry done, to helping people find jobs. So it's sometimes our bigger challenge as we're working with our homeless population, sometimes it's just finding housing that someone on a fixed income can even afford to live in. So, and the MHSA funding does not necessarily correct that problem.
Thank you.
Thanks.
All right, moving on to public health and prevention. Public health and prevention has multiple funding streams that come down, and we try to be as mindful as possible around efficiently delivering the services and complementing all of these various programs as we have multiple allocations and contracts to manage. Some of the required and in some cases optional services provided under public health and prevention include immunizations, particularly for youth, and particularly those youth who are underserved, either because they're low income or meet some other requirements. We do provide flu and other vaccine clinics to the community each year, communicable disease surveillance, pregnancy testing, TB, STD, and HIV testing and treatment. We are responsible for providing jail inmate healthcare services and also provide behavioral health and SUD services in coordination with our behavioral health division in the jail. We also operate a young, but we're hopeful to continue to grow our home visiting program, an earlier intervention program to help prevent some of the trauma and other situations that continue to perpetuate the need for our services, to be honest. We're often looking to have strong prevention programming to be able to prevent the need to have intervention from Health and Human Services for adults. We also operate a maternal child adolescent health program, tobacco education program, WIC, and other prevention programmings, including under our SUD prevention programming and outdoor and mentoring program. Aging and social services also has a heavy load to carry. This is our public assistance programming under employment and eligibility. Also child protective services and adult protective services, in-home supportive services, and all of our senior services and programming, including the senior centers throughout the county. This year, we did take on some additional responsibilities in the form of becoming the collaborative applicant for the continuum of care for the region, including Inyo, Mono, and Alpine counties. And so as part of that transition last spring, we did identify a need to do some restructuring. So as part of the budget process this year, we did restructure in Health and Human Services and established a new division, and that is called the Fiscal Oversight and Special Operations Division. It includes our fiscal services, which are combined across the department to ensure that we have, good budget oversight and preparation for all of the state and federal funding that we bring in, and have a consolidated place where all of our fiscal operations are housed. We also have an innovations and grant manager position that was newly established and has been particularly focused on our CalAIM initiative, or the complete overhaul of Medi-Cal program. So that's been very helpful to have some focus in that area this year. We also made our disaster preparedness staffing, pulled that into a department to be able to look at departmental wide preparedness and response. Traditionally, we've received funding under public health in particular to do planning and response activities for public health related disasters. And we've certainly always had a requirement to provide sheltering and mass care during emergencies. So we've pulled that up to be more at department-wide position in disaster preparedness to continue to be focused in that area. And then again, took on the role of collaborative applicant for the continuum of care, in addition to also receiving some specific funding for housing over the last year that that helps to support individuals who are receiving some services from us and have some pretty focused eligibility standards for, but we do have funding that's come down to help individuals who are in our CalWorks program or involved with child welfare services or with APS. So all of the housing related work that we have been doing to have been building out within the agency is now under that new division as well. And I started by saying that some of these are mandates, some are programs that we could choose to contract out to other agencies. We don't, we certainly do have a few agencies within Inyo County that that we've either have administered some of the programs over time or could administer some of the programs in the future, but we don't have a wide range of non-governmental organizations to contract with. So it does mean that a good number of services remain within the Health and Human Services Department, particularly those that are required. We do have a couple of slides to go over with mandates, and I'm going to try to do this fairly briefly, and we do have these listed out for your reference as well, but really want to just focus on the fact that we do have several programs that we are required to administer, and because of that, some of our it constrains us in some ways in as far as what we can do with the funding that's coming down. And so we certainly need to look at first ensuring that we've met the mandates that are associated with our programs. Most of the mandates that govern what the work that we do in Health and Human Services come from welfare and institution codes or health and safety codes. And so in the social services realm, we are required to administer the CalWorks program. And there are certain requirements associated with that program, as well as CalLearn, which is focused on ensuring that we can continue to provide educational and supportive services to teen parents. We also have a requirement to provide protective services, and so that includes child welfare and adult protective services. Child welfare in particular cannot be contracted out, and we do have social workers that provide services in both of those programs. We are required to, I'm trying to remember which one's on this slide and which one's on the next, so I don't double speak. We are required to support child welfare services and also foster care, which is addressed on the following page under WIC code 11460. So under that, we do are responsible for identifying foster placements and providing supportive services to ensure that those families are appropriately trained and licensed to provide foster care. We also, in public health in particular, have a series of required programs. Those include the California Children's Services Program, the California Health and Disability Program, Prevention Program, CHDP. That is a program that helps to ensure that regular health assessments are done on children, particularly those that are low income. That program, as we've expanded under the Affordable Care Act and expanded eligibility for Medi-Cal, a lot of those services are actually provided for under the Medi-Cal program, and our managed care plans have taken an active role in doing a lot of the case management around ensuring that that happens. So this program will be sunsetting. The sunsetting has been delayed by another year, but we will be moving out of having this mandate in public health and fully transitioning that over to the Medi-Cal program. We also operate the first 5 INYO program out of Health and Human Services, drinking driver programs, general relief, which is a safety net for individuals who are indigent and do not otherwise qualify for other types of aid. This is a program that is funded under our general fund, and so it's something that we monitor closely and have put county-specific ordinance in place to be able to administer. We are also required to have an appointed health officer. Some of you have become very acquainted with our health officer as we've gone through the COVID pandemic, but there are a variety of requirements in statute for the health officer to ensure are completed and complied with within the public health program. And finally, we have a mandate to provide a community mental health service and tobacco prevention and education program. Now on to our funding streams.
Because they're so exciting. And some of our funding streams are driven by things such as caseloads and based on baseline dollar amounts from the year before. We're going to go over that briefly. I did want to, in speaking about caseloads, it does remind me that there wasn't a department head report part in there, but earlier, so I did want to let your board know that tomorrow, Inyo and Mono and Alpine counties will all be conducting an annual point-in-time count of homeless persons who are experiencing homelessness. This is a requirement for federal funding streams to support issues related to addressing the issue of homelessness. And so we have teams scheduled in Inyo County to go out in Lone Pine, Independence, Tacoma, Big Pine, Bishop, as well as we'll be having both of our wellness centers open for people to come in, and we will hopefully be surveying and getting an idea of the number of persons who are homeless. I say that because that information is used depending on the funding stream to help inform the calculation of what kind of funding amounts will be allocated for not only the individual counties, but also for the consortium of continuum of care of Inyo, Mono, and Alpine.
That's tomorrow.
That's tomorrow.
And statewide, we have done the same thing.
Well, it's required in January. We're doing it this Wednesday, but it has to be done in the month of January. So there could be some COCs that are doing it on a different day other than tomorrow. But it has to be done in January, and you do a moment in time count, and then you can do a service-based count for following that, where you can ask the questions, but of persons coming in to access services. So we are slated to do that also, but this new role has been a little challenging for us as far as figuring out all the I dotting and T crossing that Amaka did for so many years so well, because of the coordinating these types of events is not an easy task by any means.
Did this.
Yes, yeah. The challenges of being the collaborative applicant for a whole area are many, and it's especially challenging for a small nonprofit agency. So with that being said, our funding streams are state and federal allocations or contracts, grants, Medi-Cal reimbursements. We see that primarily in our behavioral health, mental health, and SUD services. Medicare and private insurance, again, you see that mostly in our behavioral health division. The 1991 and 2011 realignment funding streams, which I'm going to go over a little bit, provide like a really broad stroke overview. CSAC has a wonderful Realignment 101 training. If you have an opportunity to attend that, it is very helpful to understand not only the health and human service funding streams as it relates to 91 and 2011, but in 2011 realignment, they also realigned other services to counties, such as the whole AB 109 with which is, and Chief Thompson will probably be speaking about this in more depth, but taking those nonviolent, non-sex offender, those lower risk individuals out of the prison system and bringing them back into communities and providing counties and realigning funding to the counties to support those services here locally. Chief Thompson will provide you the more correct information when he gets here. These rents and donations are other funding sources, and we do have, in addition to general relief and those general fund dollars that are used as required matches, the other big general fund supported program that we have is our ESSA program, which is the senior services. And this board has had an investment in our senior programs at probably a disproportionate rate than what you would see in other counties and area agencies on aging. And so all of these fundings, it's important to note, are for the most part categorical. This is how the funds come in, and this is how the funds have to be used. And they're more clearly defined. And while to the fullest extent possible, and the beauty, I think, of being a health and human services agency is we really are able to look at those funding streams in a way that where can we fit together and enhance what we can provide through blending and braiding our funding streams in order to support programming to better serve our community. So one of the reasons that we have within our senior services, for example, is we've been able to bring in a little bit of MHSA into our senior program to help support things like Friendly Visitor. We bring in some of our little social services, our social services funding to help support those areas that are naturally seen as a social service function, but are being performed and provided within the context of our senior services. Again, some is caseload driven, and some have capped allocations. So one of the things that happened, for example, in 2011 realignment is for foster care, even foster care, which is mandated, and it is considered in essence an entitlement. If you are require foster care services, you are entitled to receive foster care services. However, the amount that is allocated towards foster care for our county is a capped amount. So fortunately, we don't have a volume that has ever had us reach that cap. And we have long since put a lot of investment of our dollars and energy into providing as much preventive and supportive services to families as we can to reduce our need or risk of having kids require higher cost placements, such as a group, what used to be called a group home. So I'm going to stop for just a minute because you're right, we're on 91 realignment. So prior to 91 and following the passage of Prop 13 for all of us who lived in the 70s, that sort of had it did have an impact on the available resources to fund for the state to fund a lot of these programs. And there also have these funding sharing ratios. For example, with foster care, to match what the feds, what you could get from federal dollars, the state took a percentage and then the county was responsible for a percentage. Prior to 91 realignment, that percentage was shifted with the state having more responsibility than the county. But as the state moved beyond Prop 13 and the requirements and the resources needed continued to grow, they did this incredible realignment process where they took and realigned state responsibilities to counties with and also dedicated funding streams to support those, so that when we get realignment funds, it's intended basically to be covering the state match for and the state portion of providing these services. However, they did change the funding sharing ratios and gave local areas more of the funding cost than they had. So they, the state assumed they experienced after reductions, they experienced some challenges. The realignment proposal was in the governor's budget in 91-92. And it included not only health services, indigent health, that is why we're responsible and provide general relief, community mental health and local health services to counties, and changed the cost ratios. But it also earmarked the monies to support this. It earmarked a 0.5 cent of sales tax and vehicle licensing fee funding to support this, so that there was a reliable funding stream to support those. Understanding that over time you might have during an economic downturn like we saw in 2008, you might not get the same amount of base resources as you had the year before, but for the most part there is a reliability that you're going to receive that sales tax and vehicle licensing fee. And this was seen as such a success by the state that in 2011 they decided to realign additional programs and or services to the counties. So they broadened the scope and they included some criminal justice programs. Again, shifting the responsibility and funding for a series of major programs down to the local level. For HHS, that was specifically mental health services, substance abuse treatment, child welfare programs, adult protective services, and CalWorks. They were all realigned to the counties. And in order to offset the cost to that, they also established 1.0625% sales tax to support that realignment, and an increase, I believe, of a half a cent on the VLF percent, half a cent per percent.
I will say, I mean, we got 30 years of history with all of this at this point, and certainly there's hiccups here and there, but having this work done on the local level as opposed to having a state agency trying to figure out how to do this in Bingo County, I think overall it's been a big positive for our situation. It's annoying and confusing as
Well, and I think it's more than anything else. I think it can be confusing to understand the funding streams, at least for me. But I think you're right. That local control does allow for exactly that. It allows for more local control. And 2011 actually allowed for more flexibility, which has been really nice, especially in how you execute the programs. And I think we've really benefited from that. So we're going to talk with you now about some of the department initiatives. And I know that was like, that felt like a really abrupt transition. That's but if we talk about the funding streams too long, you'll last over on me. But again, I would encourage anyone to, the CSAC is just, it really is an incredible training.
It was good, but talk about glassing over. It was long.
Digging into the detail is
Yeah,
quite the experience.
this was a good.
All right. So a couple of the department initiatives that we've been working on over the last couple of years include our justice, equity, diversity, and inclusion focus, as well as our focus on becoming a trauma-informed agency. So I want to talk to you a little bit about those initiatives and where we're going in the future. We formed a Justice, Equity, Diversity, and Inclusion, or JEDI for short. We like that name. It sounds super exciting. We did form an internal team in fiscal year 2020 and 21. So as we were entering or going through the pandemic, we pulled our staff together as not only a need that had been identified from within, but also as we were seeing some of the health disparities that were coming out and really getting some focus as part of the pandemic response. We had a group of employees that were really interested in pulling together and helping us look internally at what types of systematic practices that we might have in health and human services in delivering services, and how do we bring those services more equitably across the county. So not only looking at things like, racial equity and gender equity, but also looking at how can we provide equitable services across very rural areas of the county, and that certainly is an area that the state is focused on as well. So we formed this team has been more of a opt-in, opt-out, grassroots kind of organization up until very recently. We did have the opportunity to establish a position, an equity and diversity coordinator position, and primarily that person is focused right now on ensuring that we meet some requirements under a health equity grant that we have received. So looking at assessing community-wide what how equitable the healthcare services are in Inyo County and developing a plan around that. So our focus has really gone towards health equity more recently, but we have over the last couple of years not only coordinated internal team meetings, but also brought in members of the community to speak to our employees in Health and Human Services to help bring some fresh perspectives and ideas on how we can continue to be more equitable in our service provision. We also have embarked on a journey to become more trauma informed. We do serve a lot of individuals who've experienced significant trauma, particularly as children. We see that cycle perpetuate if it's not addressed, and so we've really been focused in coordination with some other partners, including probation and Owens Valley Career Development Center, Toyabe Family Services, and others who've brought in some training. We've been able to train over half of our staff so far through a program of where we've trained trainers in each of those organizations and have a goal of training all of our staff to be able to not only identify trauma, but look at how to really understand how that trauma plays out in people's lives, how that impacts their overall health outcomes throughout the course of their life. And also to really focus on the secondary trauma that our staff may experience. When you're thinking about some of the really difficult situations that our social workers or our mental health professionals are dealing with, the realities of how hard the job can be and how that can start to impact our staff have been an area of focus for us. So we are also focused on how to continue to support our staff in some of these difficult positions where they're dealing with a lot of individuals who experience significant trauma. So far this year, we've been able to train over half of our staff. Our goal is to finish and train everybody else by the end of this fiscal year. And then another initiative that Marilyn in particular has been really focused on as a goal of hers as the director is continuing to grow our staff, provide opportunities for growth within the department or within the county as a whole, and how to in particularly grow our leaders. So we're going to be moving towards expanding our use of the 360 degree evaluations. This is something that Marilyn has used to assess her own performance in a modified way by gathering feedback from employees within our department, as well as peers and her management team. We are rolling out the use of these types of evaluations with all of our leaders within Health and Human Services this year, so that we are all receiving feedback from individuals who we supervise and our peers and our leaders. So just another way for our leaders to really gain more insight and be able to become better at what they do so that they can support the important work that our staff are doing. So that will start. We just, I think, finished our contract with Qualtrics, who's providing that service, and we'll be rolling that out this month, starting with our first 3 supervisors within our department.
Can I ask you a quick question?
Yes.
Just in really, really general terms, is the scope, the training for being trauma informed, is that a wide scope or is it more specific categories?
I would say it's fairly wide. I mean, we are focusing on the training incorporates scenarios of different types of trauma, focusing on how we engage with the clients that we serve to be able to help build the resilience of the individuals who've experienced the trauma, to help them move forward and have healthier outcomes. So I guess it's fairly broad, but it's within a framework that's used broadly nationwide. I'm not sure if I answered that question.
It does.
Okay.
If I could, I think a good example would be when you have a kiddo, a little foster kid who reacts to something in the home that is what we would consider pretty typical part of just being in a home and setting boundaries, and the reaction is really strong. Instead of just focusing on the reaction and correcting the behavior, finding out what is it that's contributing to that. Because sometimes what's contributing to that is that whatever just happened triggered something from their own experience. And if we can ask the question, what's behind the behavior, then we might be better able to help address that issue and help people learn different ways of moving forward. So it's just, oh, maybe you're there. Let's do it. Okay.
All right. We will get into some of the initiatives that are coming up for Health and Human Services in a little bit more detail, I think, with our division specific workshops. But just to name some of the things that we'll be focusing on in the future year or so, we're continuing to work through the CalAIM, California Advancing and Innovating Medi-Cal is what CalAIM stands for. But again, a major overhaul of the Medi-Cal system. We're really looking at how to bring in additional supportive services to help improve health outcomes and in particularly low-income individuals. We have just finished a planning process for a crisis care mobile unit, which is something that's been piloted and is now being rolled out as a requirement for all county behavioral health services, where our focus in our crisis response. So not only do we provide counseling services and medication support and services to individuals who have a serious mental illness, but also are required to respond to individuals in crisis. So in our on-call system, typically what we're doing is identifying individuals who may be at risk to self or others. So in other words, someone who may be suicidal, for example, and providing some support right there in that moment. And often that's done within the emergency room or in coordination with law enforcement, who are often the first responders. We're looking at moving that from the emergency room, where there may be a 5150 assessment done and a hold placed on an individual, but to really getting out to the community and not only doing more in community prevention work, but trying to do some of that de-escalation work to move, when possible, away from having to place a hold on an individual. So it's a new requirement. It's kind of it's been a really interesting process to wrap our minds around how this might work in a very rural county that's very spread out with limited resources. But we will be looking forward to what implementation may look like, and had really, really good community participation in the planning process. And I think some of you also were able to provide some input as well. So we appreciate that. We are continuing to work through the details of potentially bringing a mobile health clinic through a grant to be able to be administered. We continue to hope through Southern Inyo Healthcare District, and to be able to bring mobile services to very isolated parts of the county. We continue to roll out the Family's Urgent Response System, or FERS for short, which is a supportive system for individuals who have been in the foster care system, in ensuring that we have support to be able to mitigate crises or ensure that housing is stabilized. Anything you want to add to that? You're very familiar with FERS.
Yeah, I think that it's in some ways similar to the crisis care mobile unit, and that it is intended to be mobile in the home, in the moment when there's a crisis. And with the goal of helping to stabilize the placement. And the definition of who's eligible to access FERS is if you've been in foster care at any time up to the age of 24, even if you're 23 years old and you were in foster care when you were 1 and reunified, you're still eligible to have access to somebody to come help support and de-escalate the situation. It's typically activated through the state. The state has a crisis number that that foster youth can call, and either current or former foster youth. And they will oftentimes de-escalate. About 75% of the times they're able to de-escalate by phone. When they cannot, they deploy someone to the home by calling and activating our on-call system. So
I have a quick question. The crisis care mobile unit, as you're going through planning for that, what does that look like staffing? How do you perceive doing that?
Yeah, I can talk to you about what the ideal staffing level is and what we think we're going to be able to do here. So about halfway through our planning process, the state did issue some guidance. Was helpful. And unfortunately, it's going to be a little bit difficult for us to really meet all of the requirements of the guidance to be able to always be able to, I mean, obviously, if we were able to do that, then we would be able to get paid appropriately for it. So one of the requirements for staffing are to have a licensed professional, like a psychotherapist available to go out and do these in-field crisis response. That will be very difficult for us to do. We do have the opportunity and to still be able to bill Medi-Cal for the service to be able to do that through telehealth. So that is an option that we would be looking at. And obviously we'll also need to be very mindful of, as we're mobile, how do we make sure that the telehealth works when we're out in areas that don't have great service. So that's one component. We do plan to have, then there's some flexibility. We could have an EMT on the team. We could have a nurse on the team. We could have case management level staff. We can have peer supporters. So what's looking realistic for us is to have, for the most part, paraprofessional, non-licensed staff, the actual response, bring in clinical support when necessary, but have those case management staff or field outreach workers be able to go out into the community to do some of that earlier intervention or prevention work. And we'll continue to watch what's working in other communities. Where we've seen this be very successful is largely in urban areas. And so many of the smaller counties, I think there were 13 or 14 of us in the planning phase this year, almost exclusively small counties and maybe a medium county thrown in there. So we're continuing to talk about what this might look like for us and how we can get to the place where we can actually draw down reimbursement for the service as well.
Yeah, and the paraprofessionals that, which is the likely model that we'll go through, will have to have at least one person responding that has been trained on conducting an assessment for potential hospitalization under the 5150 code. So it is complex, and this is where we would enlist your support with your state liaisons through CSAC and RCRC to again reiterate that taking a program or plan developed in an urban area and thinking that it just is going to overlay in rural California easily is not a realistic thing. Now, if you're in a rural community and you're within a reasonable distance from urban areas, it's one thing. But when you, in our FERS, we first experienced this when we had the mandate for FERS, where we were told by the time we got called to deploy, that we had 3 hours to get to that place. Well, most of us know that if that crisis is happening in Tacoma, 3 hours ain't happening. So with the crisis care mobile unit, the rollout response that they're allowing for a rural area is 2 hours. So, there are some embedded blind spots into the planning process. So, this is just a really good example as you're working with your associations to continue reinforcing that urban responses and urban solutions don't necessarily apply real well in a rural community.
And the capacity to find trained staff that we have difficulty finding for our existing program.
Absolutely.
And then these innovative programs turn into requirements. So we have to figure it out either way.
Yeah.
All right. I'm just going to mention quickly too, for the crisis care mobile unit, one thing that did come out of our planning efforts was a desire to bring more training that's available to the community in general. One of the community level assessments that we did in behavioral health this year really helped us identify that most people who are experiencing difficulty with their mental health are reaching out to family or friends before they're seeking services from their primary care physician, or from county behavioral health. So we do have a focus on bringing more mental health first aid courses and other types of courses to help individuals in the community be more familiar with how to support their family members, their friends, and also would like to be able to look at having individuals in the community who are willing to, some may be willing to volunteer to help with the delivery of these crisis care services if we get enough training in place and have individuals who have a passion in that area. So that's something we'll continue to work towards as well. We will continue our COVID-19 recovery through this next year. We still are doing from the state level down, well, I imagine from the federal level down, we are doing some demobilization and looking at what systems will continue, what will be completely demobilized as we move forward, but certainly focused right now on learning from the pandemic and preparing for the next one 100 years from now, we hope.
Or at least after I'm retired.
We are moving on. We are transitioning to a new health electronic health system in behavioral health. That transition is just started in December, so we're still working through that transition. We also are moving to a new system, CalSAWS, in our employment and eligibility division. I am looking forward to seeing the implementation of the CARE system, which is an overhaul of the child welfare case management system that's been talked about for over a decade, I would say, since I was going to CWDA in a former position with Health and Human Services. We're still working towards that. Of course, with all of these transitions, hoping that it continues to help us not only provide good service and but be able to support the individuals we serve in new and better ways. And finally, we did talk a little bit about our continuum of care, taking on the lead administrative entity role. We have successfully applied for two regional grants for housing, and will continue to look at as we build out our expertise and capacity to be able to continue to look at other opportunities for bringing in additional housing funding.
And one of the major initiatives in behavioral health that I forgot to put on this list, and maybe that was just intentional on my part because I'm in avoidance, is Care Court, which is the governor's initiative around addressing the mental health issues experienced by many in our homeless population, who are struggling with their mental illness and are not, accessing treatment or resources, and actually modeling a court system similar to drug court. It has some big implications for us as a county, for our justice system, for our behavioral health division, and there's an expectation that all counties are online by the end of the year. So that is another major initiative we're working on. All right, so when I wrote
I was doing well with all the acronyms till you got this cow song.
California statewide automated welfare system.
Okay. That's for hiring people.
Oh, no, CalSAWS is the automated data system used in our employment eligibility that where people apply for any public assistance programming, Medi-Cal, CalWorks, CalFresh. It's an automated system up until this initiative. We were under one kind of, some of the counties were under the same program we had, which, by the way, was called CalSAWS. But LA County had their very own. And then there was a CalWINS. And this initiative, which started a few years ago, is to bring us all under one statewide automated system.
Okay.
So,
Got it.
so when we put this together and I read through it in my brain, it only took about a half hour at the most. Apparently, Anna and I are a little bit more verbose, so I apologize for not estimating correctly. So what is our impact? What do you see out of Health and Human Services? Well, I think that's really, I mean, each program has so much, but children are safe. We have seniors who are able to live independently longer because they have support from APS or IHSS or Senior Center. We have people who receive critical safety net support during difficult times, including access to medical care. We have adults and children in crisis who are supported assistance in the moment to ensure their safety. We have adults and youth who get clean and sober. We have adults and children who receive critical mental health services. We have children who are immunized and adults who are vaccinated and are receiving other public health services. Children have parents who get to learn how to parent a little differently than they have in the past. In fact, our first five is hosting a parent recognition for parents who participated in and completed the Triple P parenting program in the last year this Friday. And at this event, it'll be at our Bishop Senior Center, and they're going to have for the children, they're going to read a children's book, and it's going to be read in English, Spanish, Paiute, and it's going to be signed by one of our team members who is proficient in ASL. So we're really excited about this opportunity for our kids to experience different cultures and languages. We also have people who have more food security. We have people that get housing. We have people who find jobs, and we have people who are sheltered and supported during a disaster. Those are some of the kinds of highlighted outcomes that happen from the services that we provide. And typically every year following our All Staff Day, which is an HHS-wide day in which we come together to train and also to recognize the really good work that our team does. We typically put together a year in review from all of our different programs where we share with each other our own success stories. And I've provided you copies of those annually. And so we'll be doing that again later this year. Whew, so initiatives and projects expected. Again, we're going to continue to work on the initiatives and that we've already talked about. I did have care coordinator here.
It was there, yeah.
I thought, wow. Also, there's the opioid settlement program development. So thanks to our county council, Inyo County joined the suit against the pharmaceutical companies that really helped to create some of the opioid challenges we have in our country and we have in our own community. And this settlement is providing funds that are designed to specifically address the issue of opioid use in our community. But it's been starting to come in, and as Supervisor Griffiths indicated, so this is coming in for program development. How are we going to deploy it? How are we going to use it within the context of already being challenged with getting our services out the door? So, but we are committed because this is a critical issue in our community and in our nation. We also, again, the additional COC planning and housing program development. We have system improvement planning processes that are going on for specific programs. For example, child welfare every 5 years has to do a system improvement plan. We're in the beginning stages of that. Our IHSS, our MOU between the county and the union that represents IHSS workers. It is the period ends this September, and so we are likely going to have the union requesting to enter negotiation at some point, and so that will be happening. We're also going to be doing a senior services needs assessment next year. We'll have a our area plan due, and so we're going to start the process usually the October or November, the year before the plan is due. And that needs assessment is critical as we continue to have 10,000 people every day turn 65 in this country, and we are in need as a state and as a community to ensure that we have as strong of an infrastructure as we can within the context of our limited resources and our geographic expanse to make sure we have a good safety net for our seniors. Disaster preparedness and disaster readiness, and of course continued succession planning. And beyond those of us who are of retirement age, we also need to think even further down the future. When Anna retires, when Melissa retires, when our other team leaders retire, we need to be positioning our younger team members to be able to take over the reins. And that is one of the reasons that we want to invest in building our leaders, because we're going to need them.
All right. So we want to talk a little bit about our challenges. I think we've hit on a few of them already, so we won't get too deep into this, and I'm sure we'll have a chance to get into this in a little bit more detail with our division workshops. But our challenges certainly continue to be increasing mandates, sometimes without the funding, but even when there is funding attached with new programming and new requirements, we do have challenges in being able to quickly pivot to meet the new requirements, to recruit the staff that we need to adequately deliver the services. So, we're already stressed coming out of the pandemic. We do have, Marilyn mentioned that we have several vacancies where when our staff on the service level are just really struggling to get through the day and meet all of the needs, and recruitment takes a while because we're out there and we just don't have universities to draw from close by. So we are challenged in that way, and we're not the only ones who are. That's a common thread everywhere in the state, but particularly in rural areas. So we'll continue to move forward with getting Care Court, the Crisis Care Mobilization Unit. Those will be challenges from a staffing perspective, especially if we staff at the level that is proposed and required. We do also have 3 on-call systems, one for our jail health, one for behavioral health, and one for social services. The fact that we have that requirement does contribute to our retention of staff, especially when there are vacancies. Individuals who are on call frequently, really find that tiring and difficult over time. We're not large enough to be able to have a cadre of individuals who really love to do that on-call work. So they're not only being placed on call at night and having to respond, but also having to show up the next day and provide services effectively to the clients that they're serving. So it really is it's a rub. It has been a contributing factor to turnover in our department. We're continuing to look for ways to arrange that differently and try to prevent the need, be as preventive as possible. But we're going to continue to have that struggle from a retention perspective, and even in many cases a recruitment perspective when for individuals who are not interested in participating in that kind of system. We particularly have difficulty recruiting licensed mental health professionals, public health registered nurses. I would say we've been able to recruit some really good, strong staff in behavioral health and public health. We're lucky to have them. We really want to make sure we can retain them, but every time a vacancy comes up, it is difficult to appropriately fill that. Substance use disorder treatment providers, there's been changes over time to what the requirements are to be certified to be a substance use provider. So we do struggle in identifying individuals who meet those requirements. Child welfare and adult services social workers are always difficult to recruit. It's a really difficult job. So we get individuals in who have a real passion for that work, and for some it's not a job you can do for your entire career. We do have people move into other positions with us over time and continue to struggle there. And then just general difficulty that I think a lot of businesses are experiencing as well, not just in government work, but across the board. We're having trouble filling positions and really meeting the expectations of the workforce at this time as we've come out of the pandemic, and there's a desire to be very flexible in work and work from home. And I know we as a county are looking at how to be more responsive to that, and need to look at also, we're here to serve the public and need to be present for that. So really looking forward into the future on how to balance that well and be able to continue to provide the services while also providing a workplace that is supportive and meets the needs of our workers as well.
And the good thing is that we want to end that with the fact that we do have some strengths in Inyo County that I think are incredible. We have, well, I just want to say you have one of the most wonderful HHS teams. They're strong, they're committed. They get a little worn out sometimes, but they're strong and committed, and they really want to do a good job. They also have people in their ranks that we can grow into different positions. And I think that that's a real, I mean, I'm thinking of one person who started at an entry level and is now a program manager. And that was really growing that person over time. We have a strong, supportive county administration. Your board has been supportive of HHS, and your county administration has been supportive of our department. We also, we've had many of our team who have used the tuition assistance program offered by the county. And in one case, that person received a piece of license that has allowed them to advance even further than where they were at. And we have good county and community partnerships. Do we have glitches in how things work? Sure. And do we sometimes, step in it? Sure. But the beauty of it is that these are our neighbors, and these are people we see all the time, and we have good working relationships, and we figure out how to work together. And I think that is the beauty of Inyo County. So with that, we're gonna give you a little reprieve and let you ask any question you want.
Very good. Well, that was beautifully presented. Not easy to do, but thank you. Any comments?
Well, I'll say to both you and then also our new board members, regularly, I'm most familiar with RCRC, so I'll reference them. But for example, last week, I think it was 2 weeks ago, RCRC had an issue and they wanted to talk with HR. I suggested that they talk to HHS. They were talking to me and I didn't know what the answer was. So I asked them to set up a Zoom call with Marilyn and I think Hannah both on. They, I saw them last week, Sarah, she said, you have got great people in Inyo County because you had the end, you make points that they could use if it's navigating for rural counties. You knew your issues, you were able to communicate them. So I think that we do have HHS directors and leadership that represents us really well, not only here, but statewide. Jeff probably has similar stories to be able to relay, but I think it's important, we're beating you guys with the fire hose right now, all these things that are going on in the county. I mean, you look at the number of programs and issues, and I like that you gave the list of things that actually happen, because of HHS. That's really helpful, because it's easy to just talk about a program, but know what's coming out of it. So anyways, I want to tell you guys that, also know these guys that, but you do a great job for us. Okay.
Thank you.
I'll follow up on that. And as this presentation was happening, I was thinking there must be so many things that this is the first time you're hearing that phrase, and then IHHS, it just gets thrown out there, but there's such a long history and complicated, what all of that means, but we'll get there and then we'll keep asking questions. And yeah, I hear great things from around the state, county, HHS. It's always a challenge, and people do it. It's hard work, and I couldn't do a lot of those jobs for more than a few months before I heard. So you have some of those components. One thing I was thinking about with the recruitment retention part is I wonder how often there's flexibility or the ability to supplement the licensed folks with peer support or whatever you want to call it. People who don't have the license but have experience that perhaps are available. And I don't know, I know we do that. We have done that somewhat. I know that a lot of places they require full degree, the licensure. It's crazy what it takes to actually become a social worker, how much training to get that position, but yeah, I just wonder, looking for. Sorry.
And oftentimes it is more appropriate for the type of diagnosis and condition a person might have. They may need some an initial assessment, and they need to see the psychiatrist for ongoing medication oversight, but the actual support needed is more in concrete case management and support around medication management and those types of things. And so we do utilize that. And we just, I think we're having interviews for the peer support specialist that your board authorized during the budget process was a peer support specialist. So to the fullest extent possible. That being said, there are certain functions that require a clinician or require a social worker. So it is a balance. So
Now, we were bringing in some training for SUD counselors. Is my memory correct on that? We'll be able to train up more people that workforce, or I can't remember what level of training.
So we supported we opened up a training that allowed an individual or an employee to position themselves to then apply with us as an intern to gather their hours towards certification. We did have some people participate in that, and I think about 5 or 6 actually completed it and got their practicum hours in. And at that time, we're in positions that the entry level into SUD services was at par or less than where they were already being paid. So it was an unfortunate thing that did not, that we did not have more an entry level people participating in that training. It did, if nothing else, though, it did help, I think, for those who completed it. It did help broaden and strengthen how they responded to the people that they serve in other capacity, but it did not result in a workforce development that we had hoped. Yeah, I think that was about 6 or 7 years ago.
You wore everybody out.
I know. That's what I told Darcy. I said, oh, I think I can do it in an hour because I'll try and give them as much information as I can, get it done in 45 minutes, 15 minutes of questions, but they'll be so glazed over they won't have any. There was a plan.
There was a plan.
Madam Chair, we do have a hand raised.
Okay, go ahead.
Haley, can you promote this person?
We have a public comment.
Yes, it's from Tiffany Lau.
Go ahead, Tiffany. Are you there?
Okay. We'll do it back here.
Okay, hold on.
Hi, my name is Tiffany Lau. My address is 3134 Indian Creek Drive. I actually had a couple of questions. So earlier you mentioned mental health for those experiencing homelessness. And sorry, was that funding that the county needs to apply for, or is it new requirements, or is it both? And then my other question is, I have an acquaintance who was receiving mental health and seeing a therapist, but then was cut from those services. And I was just wondering if it was an issue of like budget or staff shortage or a combination of both. So those are my questions. Thank you.
Okay. So there's not specific funding for mental health and homelessness, but it's really that we're able to support persons who are without shelter, who are also experiencing mental health. We can provide support to them through our core program. They can come in and be assessed and access services in that manner, but also through our wellness centers. Our wellness centers provide a place where people can come and get support, get linked to services, and provide as much support as possible. As far as I can't speak to your friend's specific situation, but typically we are required to assess and reassess a person's status and needs at different points, and there are times where the recommendation and the treatment assessment may or may not support the need for weekly therapy, for example, but may support that larger medication management or periodic check-ins with a therapist, but with that paraprofessional, that case management, that peer support person connected to provide additional support. So I'm not able to speak to an individual situation, but people are not cut off because there's no funding. It's much more based on their clinical needs.
Thank you. Okay, any other questions?
We have another hand.
Okay, go ahead. Justin, go ahead, Justin.
Good afternoon, Justin Caparuso, on behalf of HealthNet California Health and Wellness. I just wanted to echo Supervisor Kingsley's comments. We really appreciate working with both Marilyn and Anna on initiatives in Inyo County as well as the Eastern Sierra, and look forward to a partnership as we launch the CalAIM initiative. But just wanted to reiterate, HealthNet California Health and Wellness is looking to partner in the community, partner with the county, and we're here to address any of these concerns, and really enjoy working with RCRC and Inyo County on doing so. So thank you very much for the presentation today.
Thank you,
Thanks,
Justin.
Yeah, thanks a lot, Justin.
Have them there. Okay, anything else? No. Okay, any other questions from the board? Not at this time.
You got public comments.
Hey, thank you.
I was wondering if we had any trouble. Anyway, thank you so much. Appreciate you guys, and we'll look forward to the different agency.
Make sure you point out to Mike that he didn't get in. Okay.